optimistic to see a progression-free survival improvement. There's no doubt that at the emergence of an ESR1 mutation, a switch to a drug that will counteract that mutation makes a lot of sense, and that's what we saw, that it led to a improvement in progression-free survival. I think the question, though, is what is the comparison to patients who wait until radiographic progression and move on to next line of therapy? And I think this is complicated because we have so many newer drugs, biomarker-driven targeted therapies that also impact in a positive way progression-free survival. And so the question is, how do we make a fair comparison for progression-free survival advantage in patients who are switching therapy versus prior to radiographic progression versus those who wait until radiographic progression and then switch? Right. I think, in addition to questions related to PFS too, I think from a patient standpoint, I think other endpoints like how do they actually feel, quality of life measures, time to deterioration, which was actually a positive outcome on the SERENA-6 study, time to chemotherapy, and overall survival are really going to matter as we're having these very nuanced discussions on, hey, your cancer hasn't progressed yet by imaging, but there is this emergence of something you cannot see that may counteract the efficacy of what we're currently giving you. And we want to make a treatment switch prior to your cancer actually progressing. And so I think understanding the endpoints, understanding what matters to your patients, and having a very frank discussion on the pros and cons of a SERENA-6 model is going to be really important as we consider implementing this in the clinic.
Absolutely, well said.
The PRO data that you mentioned was very impactful, I felt, because it's important to remember it was a double-blind placebo-controlled trial, so patients presumably didn't know and which drug they were on. That being said, the pain scores specifically were the ones that stood out, and you wonder if it was just a question of going on to a drug that has less arthralgias. Even though patients didn't know, I do think when patients come off of a drug that does cause a lot of arthralgias, they sort of probably could know which drug they were on. But the other thought is maybe, we all have these patients that, for example, have bone-only disease where you can't pick up the progression on imaging, but they just start to not feel well. Maybe there is some subclinical progression there that's going on that's increasing bone pain or other parameters of pain. And we did see an improvement in terms of quality of life. So I think that was most meaningful to me. The study design was a bit challenging, as Manali pointed out, in terms of understanding the impact of PFS2 with the imbalance in treatments and how many both arms received. But I think the quality of life data is more impactful in my mind because we don't want to lose the forest through the trees, so to speak. The primary goal in the metastatic setting is palliation.
Mm-hmm. I think you both make some really critical points here, and I like the point about quality of life for sure, time to chemotherapy as well. When I put all of this together, my thoughts are we really do want to extend the amount of time that patients are spending in that first-line therapy, and whether that translates to an overall survival benefit, we have to wait to see the maturity of that data.